Welcome to the Deep Dive. Today, we're plunging into a really complex area, one that touches millions of lives, the world of medications for mental health. It's vast, it can be confusing, and it's deeply personal.
Absolutely.
So our mission today is to take a deep dive into some comprehensive sources on psychopharmacology. We're not just listing drugs here.
No, definitely not.
It's more about understanding the nuances, the risks, the careful thinking that has to go into using these medications. We want to pull out the key insights so you feel truly informed. We're mainly using a detailed overview, like the Psychopharmacology Overview handout from St. Paul's Hospital in Vancouver. It does a good job distilling some complex stuff.
It's a solid resource.
Okay, so let's unpack this. There's some surprising things in here and some really crucial safety details that everyone should probably know about. So first off, psychiatric medications. We're talking about treatments for a huge range of conditions, right? Anxiety, insomnia, schizophrenia, depression, bipolar.
And even substance use disorders like opioid and alcohol use. It's a broad spectrum.
Exactly. But here's something our sources highlight right away, which I found interesting. In psychiatry, those minimum and maximum doses, they're often more like guidelines.
Flexible guidelines.
Yeah, and the studies available can sometimes be, well, the source says, less than ideal.
Yeah.
Plus, using multiple medications at once, polypharmacy is apparently pretty common.
Unfortunately, common, yes.
Which means treatment often ends up being practitioner-specific and empiric. Basically, based on the doctor's experience and what they observe, may be more than strict evidence sometimes. It sounds almost like an art form.
That's a great way to put it, actually. That art aspect is really significant. It reflects the incredible individuality of, well, everyone.
How so?
Well, think about it. Everyone's brain chemistry is unique. Their life experiences differ. Their genetics. And mental health conditions themselves don't present identically in everyone.
Makes sense.
So responses to medication can vary wildly. That's why care has to be tailored. It's about careful observation, adjusting things for the individual person, not just treating a diagnosis on paper. It really underscores the need for that personalized approach.
That really does reframe things. Okay,
Yeah.
Let's shift gears a bit. Let's talk about a group of meds that offer like quick relief but come with some pretty serious warnings. Sedatives, anxiolytics, hypnotics. Specifically benzodiazepines, or BZDs.
Yes, the benzos. Widely used.
Very widely used, it seems. For
Yeah.
insomnia, panic attacks, general anxiety, even things like alcohol withdrawal, seizures, acute mania. But here's where it gets, well, really interesting and maybe a bit worrying. The sources are very clear about critical adverse effects, especially withdrawal if you stop them suddenly.
Yes, withdrawal is a major concern.
We're talking severe stuff.
Yeah.
Sweating, shaking, nausea, rebound anxiety that's even worse than before, racing heart, agitation, and this is the big one, seizures.
Which can be life-threatening.
Exactly. And these symptoms can apparently start just a day or two after stopping the medication.
It can happen quite fast, depending on the specific BZD.
And here's a key stat from the source. 30% of patients get withdrawal symptoms if they stop abruptly after just 8 weeks of treatment.
Just 8 weeks. That really highlights how quickly physical dependence can develop, even with therapeutic use.
Right, so it's not just about misuse, it's about regular use too, which means that tapering off slowly under medical guidance is absolutely vital after longer-term use, often using something like diazepam because it lasts longer in the body.
That careful taper is crucial.
And beyond withdrawal, there are other issues. Sedation, dizziness, that kind of hangover feeling, memory problems, increased risk of falls, especially in older adults, and of course, dependence and potential for misuse.
All significant risks.
The sources also point out something about how they work for anxiety. They're good at calming the physical stuff, the racing heart, the restlessness.
The somatic symptoms, yes.
But they apparently have little effect on the deeper sort of psychic or cognitive symptoms. The worry itself might still be there.
That's an important distinction. They manage the physical expression more than the root cause, often.
And sometimes they can even backfire, right? Causing irritability, impulsivity, agitation, paradoxical effects.
Yes, particularly in certain groups, young people, the elderly, those like neurological issues. It's not common, but it happens.
There's also a difference between the long-acting ones, like diazepam you mentioned, good for tapering, but more daytime sleepiness. And the short-acting ones, like lorazepam, may be better for sleep, but more risk of rebound anxiety between doses. And there's this Aladi group. lorazepam, oxazepam, temazepam.
Right, the LOT drugs. They're generally preferred in elderly patients or those with liver problems because they're metabolized differently, more cleanly, you could say. Less risk of accumulation.
Okay, good to know. And precautions.
Mm.
Definitely need to be careful. History of substance use is a big one. Combining BZDs with opioids, that's a huge warning.
Extremely dangerous. Profound respiratory depression, coma, death. It's a major public health issue.
And also concerns with sleep apnea, COPD, pregnancy. Something called floppy infant syndrome.
Yes, and potential withdrawal in the newborn if used late in pregnancy.
There is an antidote, flumazenil, but the source says its use is limited.
It is because if a patient is physically dependent on BZDs, giving flumazenil can rapidly reverse the BZD effect and actually trigger seizures itself. So it's used very cautiously.
Wow. Okay, so given all that, the recommended duration is pretty short. As an add-on for anxiety, reevaluate every 4-6 weeks. As a sleep aid, no more than 4 weeks.
That short-term focus is key. The guidelines really push for using them judiciously and for the shortest possible time needed.
It's quite a balancing act, isn't it? That immediate relief they offer can be so helpful for someone in crisis.
Absolutely life-changing in the short term for severe anxiety or panic.
But then you have these hidden dangers, the dependence, the withdrawal. It raises a big question, doesn't it? How do patients and doctors manage that? Get the short-term benefit without sliding into long-term problems?
That is the central challenge. It requires a very clear plan from the outset, short-term goals, constant reevaluation, and really, really good communication and patient education about the risks and the exit strategy, essentially. How and when to start safely.
That hidden danger point is so critical.
Okay.
Moving on, let's talk antipsychotics. These also have a wider range of uses than you might think, not just schizophrenia.
True. They're used for other psychotic disorders, certainly, but also bipolar disorder, sometimes added for depression, PTSD, delirium.
And even managing difficult behaviors in dementia, though that's often controversial.
Yes, behavioral and psychological symptoms of dementia, or BPSD. It's an off-label use with significant risks, but sometimes considered.
So these drugs fall into different generations, right?
Yeah.
First generation, second, maybe third, based on how they work.
Broadly speaking, yes. The first-generation antipsychotics, or FGAs, primarily block dopamine D2 receptors. The second generation, or SGAs, block dopamine 2, but also serotonin 5-HT2A receptors, among others. The idea was this might improve efficacy and reduce certain side effects.
And did it. What are the main differences in side effects?
It's more of a trade-off, really. FGAs are more known for causing extrapyramidal symptoms, EPS. These are movement-related side effects.
Like what kind of movements?
Things like acute dystonia, muscle spasms, often in the neck or eyes, akathisia, this intense inner restlessness, feeling like you have to move, and pseudo-Parkinsonism symptoms that look like Parkinson's disease, like tremor, stiffness, slow movement.
Okay. And something called tardive dyskinesia.
Yes, TAD. That's a potentially irreversible condition involving involuntary movements, often of the face, jaw, tongue, sometimes limbs. It's a major concern with long-term FGA use. FGAs can also raise prolactin levels.
Yeah, and the second generation, the SGAs.
Yeah.
Less movement stuff, but other problems.
Generally less risk of EPS and TD, although not zero, but they are more commonly associated with metabolic side effects. That's the big trade-off.
So things like weight gain.
Significant weight gain, yes, and increased risk of high blood sugar, potentially leading to type 2 diabetes, and high cholesterol or triglycerides. These metabolic issues are a major focus with SGAs.
And the sources also mentioned a really crucial point. While these drugs are good for positive symptoms, hallucinations, delusions,
They work well there, generally.
they say no antipsychotic really helps much with negative symptoms, like emotional flatness, lack of motivation, social withdrawal.
That's a significant unmet need in schizophrenia treatment. Negative symptoms can be very disabling, and we still lack highly effective treatments for them.
Good point. Oh, and they mentioned long-acting injectables, LAIs?
Yes, LAIs. These are formulations of antipsychotics given by injection every few weeks or even months. Things like Risperdal Consta or aripiprazole Maintaina.
And the main benefit there is adherence, making sure people actually get the medication.
Exactly. For patients who struggle with taking pills daily, perhaps due to the illness itself or side effects impacting motivation, LAIs can be a game changer. They ensure continuous treatment and can significantly reduce relapse rates.
That makes sense. So connecting this all back, it really highlights the need for precision when choosing these, doesn't it?
Absolutely. It's not one size fits all. You have to weigh the target symptoms against these very different side effect profiles for each specific drug and generation. It requires careful consideration of the individual patient's health, risk factors, and preferences. It's a complex decision-making process.
And that precision, that complexity, it gets even more intense when we talk about the next drug, clozapine.
Mm.
Here's where the sources say it gets really interesting.
Clozapine, a unique case.
Unique because it's apparently more effective than all other antipsychotics, especially for treatment-resistant schizophrenia cases where nothing else has worked.
That's correct. It has superior efficacy, particularly in those difficult-to-treat situations. It can be life-changing for some individuals.
And it's it's reserved for those cases because of incredibly serious potential side effects.
Exactly. The risks are substantial, which is why it's not a first-line agent and requires intensive monitoring.
Let's break down that monitoring because it's serious. First, myocarditis, inflammation of the heart muscle.
Yes. It's a rare but potentially fatal risk, highest in the first month of treatment. Mortality rates cited are around 10–23% if it occurs.
Wow. So monitoring involves weekly checks of heart markers, like troponin and CRP, for the first 4 weeks.
Correct. Close cardiac monitoring is essential early on.
Then there's agranulocytosis. This is a dangerous drop in neutrophils, a type of white blood cell.
Precisely. It severely compromises the immune system, making patients highly vulnerable to infections, which can be fatal.
And the risk is highest in the first 6 months.
Yes, that's the period of highest risk.
So the monitoring for this is incredibly strict. Mandatory enrollment in a patient registry. Weekly blood work checking white blood cell and neutrophil counts for the first 6 months, then biweekly, then monthly if things remain stable.
That's the standard protocol in most places.
Yeah.
Very rigorous.
And the source mentions yellow alert and red alert levels.
Yes, those correspond to specific neutrophil count thresholds. A yellow alert means increased monitoring, maybe adjusting the dose. A red alert means the neutrophil count is dangerously low.
And a red alert means stop clozapine immediately, notify the registry, and the patient gets non-challengeable status.
That's right. Non-challengeable means they can never be prescribed clozapine again due to the high risk of recurrence. Pharmacists also have a key role. They must verify the patient's enrollment and check that their blood work is up to date and safe before dispensing each supply.
Incredible layers of safety. And then, surprisingly, another critical issue is constipation.
It sounds mundane, but it's incredibly important with clozapine. It occurs in about 15% of patients.
And it's not just discomfort. It can lead to something called autonomic ileus, where the bowel basically stops working.
Yes, and that can lead to bowel obstruction, perforation, sepsis. The source notes a mortality rate of around 7.3% for clozapine-induced ileus. It's a serious complication.
So it's crucial to ask patients about bowel function routinely and make sure they're on appropriate bowel regimens like laxatives from the start.
Absolutely essential. Proactive management of constipation is a standard part of clozapine care.
Wow. Clozapine really presents a stark ethical dilemma, doesn't it? Unmatched effectiveness for some.
Life-saving effectiveness, potentially.
Balanced against these incredibly high-risk side effects and this burden of intensive monitoring, it really makes you think about informed consent. How do you empower patients and their families, their whole care team, to make decisions in these high-stakes situations?
That's exactly the point. It requires deep, ongoing conversations about the potential benefits versus the very real risks. It demands shared decision-making, robust patient education, and a strong therapeutic alliance built on trust. Patients need to understand why the monitoring is crucial and be active participants in managing their own safety.
Deep trust and open communication. Okay, let's shift to antidepressants. Also widely used.
Yeah.
And not just for major depression, right?
Correct. There are staples for various anxiety disorders, OCD, sometimes eating disorders.
Though the source notes not bupropion for eating disorders.
Right, due to seizure risk in patients who might purge. Antidepressants are also used for chronic pain, insomnia, IBS, preventing migraines, even helping people quit smoking with bupropion.
Lots of uses. But there are common challenges across different antidepressant classes. First one, withdrawal syndrome.
Yes, often called discontinuation syndrome. It's very common if stopped abruptly.
The source uses the mnemonic finish, which is helpful. F for flu-like symptoms.
Aches, chills, fatigue.
I for insomnia. N for nausea. Another I for imbalance, like dizziness or vertigo. S for sensory disturbances, those weird brain zaps or electric shock sensations people describe.
Very characteristic.
And H for hyperarousal anxiety, agitation, irritability.
It really underscores why you should never just stop these medications cold turkey. A slow taper, guided by a prescriber, is essential.
Absolutely. The second big challenge, serotonin syndrome,
A potentially dangerous, even fatal condition.
caused by having too much serotonin activity, usually from combining multiple drugs that boost serotonin.
Exactly. It's a drug interaction concern.
And the symptoms sound serious. Delirium, agitation, high fever, sweating, tremors, muscle rigidity, twitching, high blood pressure, rapid heart rate.
It can escalate quickly and requires immediate medical attention.
And the sources list key culprits. Combining antidepressants, especially older ones like MAOIs or TCAs, with newer ones like venlafaxine,
Yeah.
but also things like St. John's wort,
Yes, the herbal supplement.
the antibiotic linezolid, dextromethorphan in cough syrup, and some pain meds like meperidine and tramadol.
It highlights the importance of knowing all the medications and supplements someone is taking, even over-the-counter ones.
Definitely. The sources briefly touch on different classes too. SSRIs, common ones like citalopram, fluoxetine, known for maybe headache, nausea, sexual side effects.
Those are typical, yes, though often manageable.
Then TCA's amitriptyline is an example. Effective, but a big warning. Fatal in overdose.
Yes, due to cardiotoxicity. That's a major safety concern with TCAs.
MAOIs, like phenelzine. Older, effective, but require that strict tyramine-restricted diet, no aged cheese, certain wines, etc.
Right, to prevent hypertensive crisis. And they need a 2-week washout period before starting other antidepressants.
And SNRIs, like venlafaxine, can sometimes raise blood pressure or heart rate.
They can, due to the norepinephrine effect. Needs monitoring.
So linking this back,
Mhm.
understanding these syndromes, withdrawal and serotonin syndrome, it's not just for doctors, is it?
Not at all. It's critical information for anyone taking these medications and, frankly, for any healthcare provider they might see, dentist, ER doctor, pharmacist. Knowing these potential risks and interactions is crucial for patient safety, preventing dangerous situations. It really emphasizes why you need to share your full medication list with everyone involved in your pair.
Great point. Share everything. Okay, let's move to mood stabilizers and bipolar disorder. This condition involves those extreme mood shifts. The sources define type 1 as having manic episodes, maybe with depression too,
Full manic episodes.
and type 2 having hypomanic episodes, which are less severe than mania, plus depressive episodes.
Correct. Hypomania plus depression.
And the treatment approach involves managing the acute episode, whether mania or depression, and then long-term maintenance with a mood stabilizer to prevent future episodes.
That's the general strategy, yes. Stabilization and prevention.
So key mood stabilizers. Lithium comes up first, mentioned as a drug of choice, and interestingly, it prevents suicides in people with bipolar disorder.
That's a unique and very important benefit of lithium. Robust evidence for that.
But it needs good kidney function, and people need to be careful with their salt and water intake.
Yes, because lithium levels are very sensitive to hydration and sodium balance. Dehydration or low sodium can cause lithium levels to rise dangerously.
And this is critical. Lithium has a narrow therapeutic window. The difference between helpful and harmful is small.
Very narrow. Requires regular blood level monitoring.
And lithium toxicity sounds serious. Flu-like symptoms, drowsiness, becoming unsteady, ataxia, a coarse tremor, progressing to heart rhythm problems, seizures, coma, even death, often made worse by salt depletion.
It's a medical emergency. Patients and families need to know the warning signs.
Okay. Then there's divalproex, or valproic acid, another first-line option.
Also widely used, effective for mania and maintenance, requires monitoring too, like liver function and platelets.
And lamotrigine, especially important for bipolar depression, the source says.
Yes, it's often used to prevent depressive relapses.
But it comes with a significant warning. Risk of Stevens-Johnson syndrome, SJS, that severe skin rash, if it started or increased too quickly.
Correct. The titration schedule for lamotrigine must be followed very slowly and carefully to minimize this risk. It's rare, but potentially fatal.
And the source adds, if you miss doses for 5 days or more, you have to restart that slow titration all over again.
Yes, you lose tolerance quickly, so you have to restart from the beginning to maintain safety.
Pregnancy is a huge consideration with mood stabilizers, isn't it?
Absolutely. Most mood stabilizers carry some risk of teratogenicity, meaning potential birth defects, and the risk generally increases with polypharmacy using more than one.
The source highlights specific risks. Lithium linked to Epstein's anomaly, a heart defect. Carbamazepine with malformations, spina bifida. Valproic acid also with heart defects, spina bifida.
Valproic acid carries particularly high risks for major congenital malformations and neurodevelopmental problems. Its use in women of childbearing potential is highly restricted now.
Interesting. And lamotrigine is often called the drug of choice during pregnancy. Why is that?
Primarily because animal studies showed lower teratogenicity compared to others, and human data, while still needing careful consideration, seems somewhat more reassuring, particularly compared to valproic acid. But it's still a risk-benefit discussion. No mood stabilizer is considered perfectly safe in pregnancy.
It just brings up such a difficult question, doesn't it? How do clinicians balance that absolute need for mood stability for the parent's health
Which is crucial because untreated bipolar disorder itself carries risks during pregnancy.
against these significant risks to the developing fetus? It seems like the ultimate example of needing shared decision-making.
It truly is. It requires extensive conversations, weighing the risks of the medication against the risks of untreated illness, considering the specific drug, the dose, the timing in pregnancy, and crucially, the patient's individual circumstances, values, and preferences. It's a deeply personal decision.
The complexities just keep piling up. Okay, finally, let's turn to treatments for opioid and alcohol use disorders. Strategies here seem to be evolving quite a bit.
Yes, there have been significant advances and shifts in approach, particularly for OUD.
Right. For opioid use disorder, OUD, the sources highlight a big shift around 2017. Suboxone, which is buprenorphine combined with naloxone, became the first-line agent generally preferred over methadone now.
That's the trend, yes. Methadone is still essential, especially for some patient populations, but buprenorphine naloxone, Suboxone is one brand name, offers several advantages.
Like what?
Well, lower overdose risk. Buprenorphine has a ceiling effect on respiratory depression, meaning that after a certain dose, taking more doesn't increase the breathing suppression proportionally, unlike methadone or other full opioids.
Okay, that's a big safety feature.
Huge. Also, the naloxone component is there to deter misuse. Naloxone isn't well absorbed under the tongue, but if someone tries to dissolve and inject it, the naloxone becomes active and can block the opioid effect or even cause withdrawal.
Clever.
Yeah.
And fewer side effects, generally. Easier dosing.
Often fewer side effects than methadone, and it can typically be prescribed out of office-based settings, making it more accessible than methadone, which often requires daily visits to specialized clinics, at least initially. Suboxone is usually taken sublingually dissolved under the tongue.
Right. The source mentions patients need to avoid chewing, swallowing, eating, drinking, or talking while it dissolves, which can take up to 10 minutes.
Correct, for proper absorption.
But there's a critical detail here, precipitated withdrawal. This sounds nasty.
It is extremely unpleasant and a major risk if not managed correctly. Buprenorphine is a partial opioid agonist, but it binds very tightly to the receptors. So if you give it to someone who still has a full agonist, like heroin or fentanyl in their system, the buprenorphine can kick the full agonist off the receptors, but only provide partial activation itself. This causes a sudden drop in opioid effect, triggering immediate intense withdrawal symptoms.
Ouch. So how do you avoid that?
You must wait until the patient is in moderate opioid withdrawal before starting Suboxone. Clinicians often use a scale, like the Clinical Opiate Withdrawal Scale, or CLWS, and typically wait until the score is above 12, indicating clear withdrawal symptoms are present. Only then is it safe to initiate buprenorphine.
Okay, crucial timing there. Now, for alcohol use disorder, AUD, acute withdrawal first, what's the approach?
For acute alcohol withdrawal, benzodiazepines are the standard of care, the treatment of choice.
Like diazepam or lorazepam again?
Exactly. They effectively reduce the severity of withdrawal symptoms, significantly lower the risk of seizures, and help prevent delirium tremens, DTs, which is a severe and dangerous form of withdrawal.
Okay, so BZDs for the acute phase. What about maintenance, helping people stay off alcohol long term?
There are a few main pharmacotherapies. Naltrexone is a first-line option. It's an opioid receptor blocker, and it seems to work by reducing the rewarding, euphoric effects of alcohol.
So the idea is it helps prevent a lapse from becoming a relapse.
That's a good way to think about it. It reduces craving and the amount people drink if they do slip up.
Another first line is a camprosate.
Yes. Its exact mechanism is complex, thought to involve normalizing glutamate and GABA neurotransmission that gets disrupted by chronic alcohol use. It's generally considered more effective for supporting abstinence in people who have already stopped drinking.
Okay, different mechanisms. Then there's disulfiram, second line, aversion therapy.
Right. This is the oldest one. Disulfiram works by blocking an enzyme involved in alcohol metabolism.
And here's the critical detail. If someone taking disulfiram drinks alcohol, They get a really severe, unpleasant reaction.
Extremely unpleasant. Headache, intense flushing, nausea, vomiting, sweating, chest pain, palpitations, shortness of breath. It's designed to be a strong deterrent.
And its effect lasts for 1–2 weeks after the last dose.
Yes, so even small amounts of alcohol, even from things like mouthwash or certain foods, can trigger the reaction during that time.
So why is it second line? Sounds like a powerful deterrent.
Because the reaction can be so severe, adherence is often poor people just stop taking it if they plan to drink. And the evidence for its long-term effectiveness in reducing alcohol consumption is actually weaker compared to naltrexone and acamprosate. It's used less commonly now.
Interesting how the strategies differ.
What's really fascinating across both OUD and AUD is seeing how the science is continually evolving. We're moving towards safer options like buprenorphine, more accessible treatments, and therapies that target the underlying neurobiology of addiction more effectively. It offers real hope for addressing both the acute withdrawal phase and supporting long-term recovery.
That is hopeful. So there we have it. We've journeyed through the really intricate world of psychopharmacology. It's clear these medications are incredibly powerful tools.
Powerful but not simple fixes.
Exactly. Not simple fixes.
Hmm.
They're effective use demands. Well, careful understanding, constant monitoring, and really open, honest communication between patients and their healthcare teams. So what does this all mean for you listening?
I think it means recognizing that knowledge is empowering.
Taking this newfound knowledge and applying it thoughtfully.
Yeah, and maybe building on that. While these medications absolutely offer immense hope and relief for so many people, realizing that their success really hinges on a holistic approach, one that respects individual differences, that watches vigilantly for side effects, and that adapts as we learn more. It's about empowering you to be a true partner in your care.
Well said. A true partner. So, as you think about everything we've covered, the benefits, the risks, the complexities, here's a final thought to mull over. How does understanding the intricate balances and the serious considerations behind these potentially life-changing medications empower you to be a more informed participant in your own healthcare journey, or perhaps in the journey of someone you care about?